Usually when we think about breathing, there's this expectation of it just being automatic, like a background app running perfectly on your phone.
Right. You never check on it.
Exactly. You never actively manage it.
Yeah.
But the second that app crashes, the second your chest tightens and you just cannot pull in a full lungful of air, well, it becomes the absolute only thing you can focus on.
Oh, absolutely. It is this incredibly primal physiological panic. I mean, we are so accustomed to the invisibility of our own respiration that when it suddenly requires conscious effort, it fundamentally disorients the body and the brain.
Yeah, today is Monday, June 15th, 2026. And, if you ask the average person to picture someone with asthma, they almost invariably picture a child.
Yeah, like a little boy on a soccer field needing a puff of our rescue inhaler.
Right. And looking at childhood statistics, they'd actually be right. Boys have significantly higher rates of asthma than girls. But here's where it gets really interesting. If we track that data past puberty, the math completely flips. Women suddenly become 50% more likely to have asthma than men.
Which is a staggering jump when you really look at the
It
number.
really is. And even more concerning, women are 3 times more likely to be hospitalized for severe asthma attacks. So our mission for this deep dive is to answer a very specific underlying mystery within that data. Why do so many women who have never had a single respiratory issue in their entire lives suddenly find themselves struggling to breathe and relying on an asthma inhaler the exact moment they hit menopause?
Yeah, we are looking at a profound shift in the biological landscape that, frankly, often goes completely unnoticed by standard diagnostic practices. To get to the bottom of this, we are synthesizing some heavy-hitting clinical guidelines from the National Institute for Health and Care Excellence, or NICE, alongside safety warnings from the MHRA.
And we're crossing that with patient resources from Asthma Plus Lung UK, right?
Exactly. Plus large-scale data from the European Community Respiratory Health Survey and deep medical literature on hormonal science. Because this deep dive isn't just about the stereotypical menopausal symptoms like hot flushes.
Right. It's much deeper than that.
Yeah, we are examining the intricate, invisible relationship between female sex hormones, the physical architecture of the lungs, and the hidden dangers of modern inhaler reliance.
So let's start with the physical reality of what actually happens in the lungs during the menopausal transition. In the clinical resources, there's this highly illustrative patient anecdote about a 53-year-old woman named Dorothy.
Yeah, that case study really stands out in the literature.
It does. So she catches the flu, which isn't unusual, but weeks later, she cannot shake the aftermath. She's winded, just doing her standard daily routine. She develops this intense, persistent tightness in her chest.
And she actually assumes she is having a cardiac event, right?
Exactly. She finds herself having to prop her upper body up with pillows at night just to get enough oxygen. But when she finally undergoes pulmonary testing, her heart is perfectly healthy. The diagnosis is adult-onset asthma.
Which, Dorothy's presentation is incredibly common, and the underlying mechanism driving that sudden onset is deeply rooted in the sudden withdrawal of hormones.
Because during menopause, a woman's systemic levels of estrogen and progesterone drop drastically.
Right, and in a healthy premenopausal respiratory system, estrogen actually acts as a crucial smooth muscle relaxant. It interacts with specific cellular receptors to promote the relaxation of the muscles that physically wrap around the airways.
So it's actively maintaining their structural openness.
Exactly. And estrogen also regulates the hydration of the mucosal lining inside those airways.
Okay, so estrogen is actively managing both the structural width of the airway and the fluid dynamics inside it.
Yes, and when those hormone levels plummet during menopause, that biological support structure essentially collapses. You lose that relaxing effect, which leads directly to bronchoconstriction, the physical narrowing of the tubes.
Wow. And without estrogen driving that mucosal hydration, the mucus naturally present in the lungs becomes dense and sticky, right?
Precisely. Instead of acting like a conveyor belt that traps environmental irritants and sweeps them away, this thickened mucus traps pollen, pollution, and viral particles right against the airway tissue.
And then, on top of the structural and fluid changes, the immune system itself pivots. The drop in estrogen shifts the body toward a Th2-dominant immune response, which actively ramps up allergic inflammation in the respiratory tract.
It creates a perfect storm for respiratory distress.
But wait, if dropping estrogen causes asthma during menopause, shouldn't puberty, when estrogen's actually rising, cure it? Because the data shows that girls start getting asthma more than boys right after puberty begins. It seems counterintuitive that both the sudden introduction of estrogen and the sudden withdrawal of it would trigger the exact same respiratory disease. I mean, is estrogen like a thermostat where both too high and too low trigger the alarm?
That is a great analogy, actually. The contradiction resolves when we look at the cellular receptor level. You see, estrogen is not a blunt instrument.
Right, it's more specific.
Exactly. It operates through different receptor subtypes, primarily estrogen receptor alpha and estrogen receptor beta. Depending on which receptor is activated and the specific concentration of the hormone, estrogen can be either pro-inflammatory or anti-inflammatory.
Okay, that makes sense. So during puberty, the sudden surge in estrogen primarily interacts with pathways that trigger a pro-inflammatory response.
Yes, which initiates asthma in young girls. Then, decades later, the sudden withdrawal of estrogen during menopause removes the protective, smooth, muscle-relaxing effects mediated by entirely different receptor pathways.
So it's a completely different biological route that arrives at the exact same symptom profile.
Precisely. And that dual nature of the hormone explains why adult-onset asthma is so frequently misdiagnosed, because this menopausal asthma isn't always driven by standard allergens.
Right, it's not necessarily a sudden allergy to dust mites or pet dander.
Exactly. The symptoms mirror other degenerative lung conditions. A doctor looks at a patient like Dorothy, notes her age, sees the diminished lung capacity, and frequently jumps to a diagnosis of COPD, or chronic obstructive pulmonary disease.
They just attribute it to age or environmental wear and tear.
Yeah, completely missing the fact that her changing hormones just completely re-architected her pulmonary system.
Man, it really highlights a significant failure in how we categorize respiratory disease in adult women. We cannot treat hormonally driven adult-onset asthma with the same protocols we use for childhood allergic asthma.
No, absolutely not. The chemical drivers are entirely distinct.
And this directly connects to the role of the other major female hormone, progesterone. We have to examine what the medical literature refers to as the progesterone problem.
Right, because it's not just about the natural decline of hormones as a woman ages.
It's the actual type of hormone circulating in a woman's body, whether it's naturally produced or medically introduced, that drastically alters her lung function.
Yes, the biological distinction between natural and synthetic hormones is vital here. Endogenous natural progesterone produced by the ovaries is generally anti-inflammatory within the respiratory system.
So it reduces lung inflammation and actively suppresses the overproduction of mucus.
Exactly. It operates as a protective, stabilizing force in the airways. Synthetic progesterone, however, which is clinically referred to as progestin, does not replicate that stabilizing force.
Okay, let's unpack this, because the scale of that difference is truly alarming when you look at the real-world data. There's a study from the UK Clinical Practice Research Data Link that analyzed the records of women newly prescribed a progestin-only contraceptive.
Ah, yeah, the commonly known mini pill.
Yes, the mini pill. And the data revealed that women under the age of 35 who began taking this synthetic progestin experienced a massive 39% increased risk of suffering an asthma attack.
That 39% increase demonstrates a profound mismatch at the receptor level. Synthetic progestins are molecularly altered, so they can survive the digestive tract when taken orally.
Right, they have to be tough enough to make it to the stomach.
Exactly. And because of that altered structure, they have a high affinity for the progesterone receptors in the body, but they often fail to trigger the downstream anti-inflammatory cascade that natural progesterone does in the lung epithelium.
So they bind to the receptor, blocking it, but they just don't provide the protective signaling. It's like natural hormones are a perfectly conducted symphony, and then introducing synthetic progestin is like handing the exact same sheet music to a heavy metal band.
Ha! That's exactly it. It's the same basic notes, but the body reacts with total chaos. Mechanically, it's like using a copied key that slides into a lock perfectly, but the teeth are just slightly off.
Right, it fits into the keyhole, preventing any other key from being used, but it absolutely refuses to turn the engine over. The anti-inflammatory defense mechanisms are effectively locked out.
Which is why we see the consequences of this, even with natural hormones, in a phenomenon known as perimenstrual asthma.
Yeah, the research notes that up to 40% of reproductive age women with asthma experience a severe exacerbation of their symptoms right before or during their menstrual period.
And the biological reason is that this is the exact phase of the menstrual cycle when both estrogen and natural progesterone hit their absolute lowest concentrations.
The natural anti-inflammatory signaling simply drops out entirely.
Yes, and the clinical tragedy here, frankly, is the gender data gap and the systemic lack of communication regarding these risks.
Oh, for sure. The progestin-only mini pill is globally ubiquitous, frequently available over the counter. Yet nowhere on the box does it list asthma attacks as a risk.
Leaving women completely in the dark? A patient could be managing a heavy cycle or seeking contraception, suddenly find herself reliant on an inhaler, and neither she nor her primary care physician might ever connect the synthetic progestin to the shortness of breath.
And because this hormonally driven asthma operates on these unique inflammatory pathways, standard asthma treatments frequently fall short. Which brings us to a major safety warning embedded in the recent clinical guidelines regarding the overuse of the standard blue rescue inhaler.
Right, because the mechanics of menopausal asthma often manifest as a specific cellular subtype known as neutrophilic asthma.
Whereas standard childhood or allergic asthma is typically eosinophilic.
Right.
Yeah. Exactly. Eosinophilic asthma is driven by eosinophils, a type of white blood cell that responds robustly to standard inhaled corticosteroids, the daily preventative inhalers.
Corticosteroids essentially force eosinophils to die off, clearing the inflammation.
Yes. Neutrophilic asthma, conversely, is driven by neutrophils, which are the immune system's stubborn first responders, usually recruited for infections or tissue injury.
And crucially, neutrophils have a very low sensitivity to standard steroid treatments.
In fact, some steroids can actually prolong the survival of neutrophils in the airway.
Wow, that creates a deeply frustrating scenario for the patient.
Mhm.
A menopausal woman is dutifully taking her prescribed daily steroid preventer inhaler, but her chest remains tight and she's still wheezing.
Because the steroids are effectively being ignored by the neutrophils. And because the preventative medication is failing to provide relief, the patient logically turns to the emergency intervention.
The short-acting blue rescue inhaler.
Right, the short-acting beta-2 agonist, or SABA. These inhalers provide rapid, acute relief by forcing the beta-2 receptors on the airway muscles to relax.
So the airway physically opens up.
It does. However, the SABA does absolutely nothing to address the underlying cellular inflammation. The neutrophils are still actively damaging the tissue.
This is why the MHRA and the updated 2024 NIC clinical guidelines have issued explicit warnings against relying on this mechanism. They define overuse as needing the blue inhaler more than twice a week.
Because if a patient is using a SABA that frequently, it means the drug is merely masking the progression of the underlying disease.
The smooth muscle relaxes temporarily, giving the patient a false sense of security, while the neutrophilic inflammation continues to rage unchecked beneath the surface.
And this masking effect dramatically increases the risk of a sudden, severe, and potentially fatal asthma attack. The new NICE mandate is very clear on this.
SABAs should never be prescribed without an inhaled corticosteroid.
Exactly.
But wait, if my chest is tight, you're telling me the blue rescue inhaler is dangerous to rely on, what on earth am I supposed to do?
This raises an important question. Respiratory medicine is actually shifting toward a protocol designed to bypass this exact paradox. The updated standard of care is known as AIR, anti-inflammatory reliever, or MART, which stands for maintenance and reliever therapy.
Okay, so how does MART work?
Instead of bifurcating the treatment into a daily preventer and a separate symptom-only rescue inhaler, MART utilizes a single combination device. It contains both a low-dose inhaled corticosteroid and a drug called formoterol.
Formoterol is a highly targeted, fast-acting airway opener, right?
Yes, and the mechanics of that combined approach solve the masking problem.
Because instead of taking a preventer in the morning and hoping it works all day, the patient uses this single combination inhaler both as their baseline maintenance and as their emergency rescue when they feel tight.
Precisely. The clinical advantage is the simultaneous delivery. Every single time a patient experiences bronchoconstriction and reaches for the inhaler to open her airways, she is inherently delivering a localized dose of anti-inflammatory medication directly to the site of the active inflammation.
Oh, that's brilliant. It treats the immediate symptom and the underlying root cause at the exact same moment.
It completely eliminates the dangerous masking effect associated with the traditional blue SABA inhalers.
Having a safer mechanical treatment is a massive step forward, but the efficacy of any treatment is heavily influenced by the individual biology of the patient. The choices a woman makes regarding menopause management and her own body composition uniquely alter her asthma risk.
Yes, and the European Community Respiratory Health Survey, or ECRHS2, provides some incredibly counterintuitive data on this front.
This was a survey of over 4,200 women, right?
It was. And the baseline finding was that the physiological transition through menopause is definitively associated with a measurable drop in intrinsic lung function.
Yeah, they tracked FEV1, forced expiratory volume, in 1 second, which measures how much air a person can forcefully exhale.
Hmm.
And the data show that merely going through menopause causes the FEV1 to drop by roughly 120 milliliters.
But the demographic breakdown of who suffered the steepest decline is where the data becomes very complex.
Right, because the standard assumption in respiratory health is that increased body weight equates to increased breathing difficulty. But this specific survey found that the intrinsic drop in lung capacity hit lean women, those with a BMI under 23, significantly harder and faster than it hit overweight women during the menopausal transition.
Which is surprising to a lot of people.
It really is. Why is a lower BMI acting as a respiratory risk factor in this specific context?
Well, the mechanism lies in peripheral aromatization. Adipose tissue, or body fat, is not just inert energy storage. It is an active endocrine organ.
So the fat cells actually produce hormones.
Exactly. Fat cells contain an enzyme called aromatase, which converts circulating androgens into a form of estrogen called estrone. Lean women have very little of this adipose tissue.
So when their ovaries stop producing estrogen during menopause, they experience a precipitous, severe drop in their systemic estrogen levels because they lack the backup estrogen generator that fat cells provide.
Yes, that sudden, steep withdrawal hits the estrogen receptors in the lungs incredibly hard, causing that rapid decline in lung function. Overweight women, due to the peripheral estrogen production in their fat cells, experience a much gentler, tapered decline in hormone levels.
However, that doesn't mean gaining weight is a protective strategy for lung health, because other clinical sources we're reviewing emphasize the mechanical and inflammatory dangers of obesity.
That's a crucial point.
Postmenopausal weight gain frequently presents as visceral or abdominal fat. This physically crowds the diaphragm, restricting the ability of the lungs to fully expand.
Furthermore, that same adipose tissue actively secretes its own inflammatory cytokines into the bloodstream. So while the fat cells might provide a slow taper of estrogen, they simultaneously generate systemic inflammation and mechanical restriction.
So what does this all mean? It seems like it creates an impossible tightrope for women.
It absolutely does. A steep loss of estrogen damages lung function in lean women, while the accumulation of abdominal fat mechanically and chemically impairs the lungs in heavier women. And this biological complexity extends directly into the debate over hormone replacement therapy, or HRT.
HRT is widely considered the gold standard for managing severe menopausal symptoms, protecting bones and all of that. But when evaluating its impact on menopausal asthma, the literature is profoundly conflicted.
Highly conflicted. We have studies indicating that HRT restores the necessary smooth, muscle-relaxing estrogens, effectively improving lung function and reducing asthma symptoms.
Conversely, there are prominent studies suggesting that postmenopausal women who initiate HRT are actually twice as likely to develop new-onset asthma.
Because the hypothesis there is that the introduction of synthetic estrogens in the therapy aggressively reignites the inflammatory pathways in the lung tissue.
Women are forced to walk this tightrope of taking HRT to save their bones and sanity, but potentially sacrificing their lungs in the process.
Exactly. The contradictory data emphasizes why broad, generalized protocols are failing this demographic. The fact that HRT can either cure a woman's asthma or actively cause it means that precision medicine is the only viable path forward.
It's totally dependent on the specific receptor sensitivities and immune baseline of the individual patient.
Yes. If you are navigating this, the most effective clinical tool is meticulous correlated tracking.
Which means tracking menstrual and menopausal symptoms alongside daily respiratory metrics using an at-home peak flow meter. Bringing a correlated data set to your doctor is the only way to tell them exactly how your unique biology is responding.
Presenting localized data forces the clinical conversation away from generic assumptions and toward targeted therapies.
Well, let's briefly recap the journey we've been on today. We established that the biological withdrawal of estrogen during menopause fundamentally changes lung architecture.
And we examined how synthetic hormones like progestins can act as unexpected triggers.
Right. We also detailed why the traditional blue rescue inhaler fails to treat neutrophilic inflammation and actively masks disease progression, making it a dangerous crutch without steroids.
Which is why the shift to MART therapy is so critical. The medical world is really just waking up to this female-specific respiratory crisis.
It truly is. So to you, the listener, if you or a loved one are experiencing new shortness of breath in your 40s or 50s, it is not just getting older. It is a very real, documented physiological change. Advocate for regular asthma reviews and ask about MART or air therapies.
You have to arm yourself with the specific mechanics of your own biology to get the correct care. But before we close, there is one final, truly provocative frontier concept hidden in the clinical literature.
Oh, right. This is fascinating.
Throughout our analysis, we have focused entirely on the mechanisms of female sex hormones. But the data reveals a fascinating counter-narrative regarding the mechanics of male sex hormones. Androgens, specifically testosterone and DHEA, exhibit a profoundly protective, stabilizing effect on lung tissue.
They actively downregulate the specific immune pathways responsible for asthma exacerbations, which fundamentally explains the childhood statistics we started with.
The boy-to-girl ratio.
Exactly. The reason boys suffer from high rates of childhood asthma but suddenly see those symptoms resolve post-puberty is because they receive a massive systemic surge of testosterone that protects the lungs.
The clinical question emerging from that biological reality is revolutionary. Could the future of treating severe therapy-resistant asthma in adult women bypass traditional inhalers entirely?
Relying instead on nebulized male hormones to heal female lungs. The hypothesis is that a localized fine mist of DHEA could leverage those innate protective pathways without causing the systemic side effects of oral testosterone.
Using the precise biological mechanism that protects men to successfully heal the lungs of women, it's a wild thought to mull over.
It really is an incredible concept. When the hormonal architecture shifts and that automatic background breathing app crashes, the medical community is finally beginning to write the targeted updates required for women's bodies. Thanks for joining us on this deep dive. We'll catch you next time.